Welcome to today's webinar. A few more people are joining us, still in the waiting room. Okay, welcome back. Nice to see you all again. All right, I think we can get started and the others will join us in a minute. I hope everybody is having a nice rare disease week. I'm sure all of you must be pretty busy with communication, awareness, campaigns. So this might be today's webinar will be a good distraction, I think. All right, I think everybody is in the room and we can get started. Okay, welcome again. It's great to have you all here. Before we get started, just a couple of quick housekeeping notes. This session is being recorded. Hopefully this time will work. And the slides will be available on your training page in a day or two. If you have, as usual, if you have any questions during the webinar, feel free to drop them in the chat or raise your hand if you'd like to speak. We'll also have a dedicated time for questions at the end of each presentation today. And also, please keep an eye on the chat. We'll be sharing the link to the attendance sheet. Remember to sign in as the attendance is recorded separately for each session. So during each webinar, we'll share the link to the attendance sheet. You just need to mark your attendance. Okay, getting started. Today we have two presentations lined up. First, we'll cover an introduction to data codification, standardization, and disease identification. Then we'll move on to Orpha codes and the Orphanet nomenclature for rare diseases. We're lucky to have two fantastic speakers with us today. We have Caterina Lucano, she's the Orphanet Scientific Team Manager, and Ronald Cornet, who is a professor in medical informatics at Amsterdam UMC. I don't want to spend too much time on the introduction, so let's dive in. I'll hand it now over to Ronald to kick things off. Ronald, whenever you're ready.
Yes, I'll start sharing my screen.
Thank you. Perfect. Works fine.
And I don't think you see that works like that.
Yep.
Okay. So, well, first, thanks for providing me with the opportunity to join you in this webinar, especially as, like you pointed out, it is a Rare Disease Week this week. Many things going on, and well, I think more than ever important to continue to raise and increase awareness on rare diseases. So it's my pleasure to start with introduction of data codification, standardization, and disease identification, as is the title of today's presentation. And just briefly about me, if I get the next slide. So as mentioned, I'm a full professor in medical informatics. My focus is on reusable health data. So how do we make sure that data can actually flow from, healthcare practice where data is being collected to healthcare registries for analysis and other purposes to really support the use of so-called real-world data to create real-world evidence in order to improve the quality of care and for rare diseases, especially shorten time to diagnosis, for example. So I do that also in my teaching role at the university as a principal educator on FAIR data, which I will briefly address, and as a principal investigator. And I do that in a bunch of projects. There's ERDERA, the European Rare Disease Research Alliance. There's Helios, which is a European cost action around rare hematologic disorders. the HEMA project, also focusing on rare hematologic disorders and especially data harmonization and making data fair. A Dutch project on disease and drug-drug interactions, which is called Leapfrog. Paladin, which is an IHI project focusing on neuromuscular disorders, in the context of which we are developing a so-called interaction in which we can bring patients, providers, and researchers together to further knowledge on rare neuromuscular disorders. And in about a month from now, we'll kick off the Learn Fair program in the Netherlands, where we will work on further training on, well, adequate use and preparation of data for making it useful for multiple purposes and for doing research on. So, well, I think this presentation fits in that line. And, well, I thought, well, taking the title, it may be good to, well, debunk the buzzwords. So, and that's basically the three topics of today's presentation. Data standardization, which is basically, well, representing data in a standardized way, and I'll get to standards later. Data codification, which is basically using codes for standardization. And then disease identification to the use of codes for a standardized representation of diseases. So, well, looking at data standardization, I thought, well, let's take a real world example. I put in some synthetic data. So on the bottom, you see the form which I received on the participants in this webinar series. And well, as I say, I made it up. So I put myself on the first line, being a senior researcher from the Netherlands, Amsterdam, UMC, with a number of areas of interest. And then as a second participant, which is also made up, a patient advocate from Belgium, involved in endo-ERN, focusing on rare bone diseases. And I'm not saying that such a person doesn't exist, just wasn't in this list of participants. So this structuring is basically an other representation than, well, in my case, a free text description, which we often have patient records describing things. In this case, something like me being a full professor from Amsterdam, UMC, the Netherlands, with a research focus on reusable health data in the domain of rare diseases, with projects on rare diseases at large, rare hematologic diseases, and neuromuscular diseases. So creating these, and often I must admit they are Excel spreadsheets, for better or worse. This is a first level of structuring or standardization, if you will. We choose the headings and we, well, fill in the values for each of the headings. And then this is where the standardization comes in, because having a structure like an Excel spreadsheet doesn't equal being standardized, because, well, we need standards to be able to scale up. And this is a data set which is only used for this purpose, so there is not much use for standardization. But often, and especially, of course, when we deal with disease data and patient data, health data even, these data can serve multiple purposes. And then we want to scale up and bring data sets together to either have more attributes on a single patient or maybe have more patients with certain variables. So, and then we get standardization with questions like, okay, what do we use as an identifier for participants? Is it an incremental number like it is in this spreadsheet, or would we want to use social security number? Well, not in this case, of course. What is actually relevant about participants? So in this case, it was considered that knowing the profile, the country, the organization, and the disease areas is interesting information. But that would be something that if you want to scale up, you need to agree what's the relevant information to be captured about patients. And if we know what we want to capture, then the question is, what's the exact meaning of data elements? So is country the country where I live, the country where I was born, the country where my organization is? And well, disease in this context clearly doesn't mean, well, hopefully also doesn't mean having disease, but as a disease area of interest. So, and then the last question is, which are allowed values for each of the data elements? So that as profile, we have, I think the original was young researcher, and then I added senior researcher, patient advocate, countries, etc. All of this needs to be agreed on, and basically agreeing on something with a larger group means standardizing. All of these items need to be standardized in order to be able to scale up. So if we do that, then we get a clear meaning of our data elements. So basically the labels in row 1, and we get better understanding and agreement on the values in each of the cells. So what we then basically create with these data elements is a so-called schema or information model, or maybe you know it as a data dictionary or as a code book, which is basically the specification of a data structure. And well, I present here one example, which is the set of common data elements for rare disease registration, which is, well, as it says, a set of common data elements focusing on rare disease registries. And in this context, it is specified that we have an element pseudonym, which is described as the patient's pseudonym. There's a date of birth. There's sex, which is described as the patient's sex at birth. So that's already an important, well, clarification of the element label sex alone. There's patient status, date of death, first contact with specialized center, etc. So we see the descriptions and we see allowed values, be it strings, be it dates, or be it categorical values like female, male, undetermined. And then there's some additional information. So this is a first way of standardizing the structure of the data. But then we're not there yet. We also need the data codification to not only standardize the structure, but also the content. Because if we start codification, it helps to uniquely identify both the data elements and the values. And that's important because in that way we can make the information independent of languages or synonyms being used. And as an example, I took a participant identifier with a Finnish and an Arabic translation. And well, it clearly shows that unless you speak any of those languages, you wouldn't have a clue what it really means from the label alone, even though for the English label, it may be clear. So what we need to do is codify, add a code to, in this case, the data element participant identifier. And in this case, I choose a code system, which is called LOINC, which is a code system specifically providing observation identifiers. And a participant identifier is a kind of observation for which we can use a code. And in this case, in LOINC, it is code 82787-3. So then we can represent it either separately, always represent the code system, because if you don't know what system it comes from, then a code itself may be ambiguous. Or we can combine them and write them as a URL, as a really a web address, loinc.org/ and then the code number. And when we do that, we often also use shorthands and we say, oh, LOINC actually stands for loinc.org. And we can just write LOINC : 82787-3. And in that way, we can add the codes to all of the data elements. And well, the important thing is, as I said, it helps to uniquely identify these data elements. And here we see the example of the LOINC code with some descriptions. So it is patient identifier or participant identifier, and the short name is participant ID. And it provides some extra information about what this code describes. And I can do that for each of these. And I took the liberty of changing the profile to role. And I can find a role data element code in, well, which you see here, w3.org/2006/vcard. I found and I interpreted it as country of current residence, for which I can find the LOINC code. I can describe affiliation with a schema.org code, and I describe the disease as topic of interest with a code coming from FOVE. And you see actually in the last two, and also for role, that codes are not necessarily numerical or alphanumerical codes. It can also be like mnemonical codes, which are here affiliation, role, and term topic interest. And then I can do the same coding for the values. So below you see that for senior researcher, I took a code from the NCI thesaurus, and I did the same for patient advocate. For the Netherlands, I took an ISO code, ISO 3166-2, where the code is NL, and for Belgium, the code is BE. I took the identifiers, the so-called RORs, the Registry of Research Organizations, and I found the codes for Amsterdam UMC and for ENDO-ERN. And, well, for later, there are the diseases that I would also provide codes for. So if we take these steps and we codify all of the basically the column headings, or row one, if you will, the data element names, and we codify as much as possible all these categorical values in our data set, then we have like maximally codified a data set. And what you may have seen from this example is that, well, there's definitely not one system to rule them all. I use LOINC, which is geared towards observations, vCard for describing people and organizations, schema.org for structured data on the internet, the FOVE vocabulary, which stands for friend of a friend, the NCI thesaurus, the ISO codes, and the research organization registry. So 1, 2, 3, 4, 7 different coding systems to codify this data set. And well, like I say, there's no one code to rule them all. We use a multiple of coding systems. And well, selecting the right system actually requires some training and tools. And I provided links to a number of tools here, the ontology lookup service, NCBO bioportal, the meta thesaurus from the Unified Medical Language System of the National Institutes of Health in the US, and the linked open vocabularies. Each of these bring together codes from a multitude of coding systems. And well, these systems helped me to determine that, for example, NCI thesaurus was a good choice to specify the roles like senior researcher and patient advocate. So it's important to realize that coding systems offer, well, quite some functionality, like synonyms and descriptions. We saw participant identifier and shorthand participant ID. They may also provide these descriptions in multiple languages, LOINC, and I know also Orpha codes, they come in different languages. The same goes for SNOMED CT. They may provide mappings or a means for mapping among coding systems. so that we can, for example, point out that the ISO code NL is actually the same as the SNOMED code with this number 22 yada yada 001. And it can provide additional information about the item being described. So it could provide some information about countries or some information about diseases. And the important thing of using these web-based codes is that you can link to web resources. Plus, and then we bridge to the domain of disease identification, they provide a means to store and retrieve disease data at a basically arbitrary level of detail. So when we capture information about patients, sometimes we have detail, and for example, we have determined that the patient has type 5 osteogenesis imperfecta. If we have that information, we might want to capture that in a system. But it may also be that the exact type is unknown, but it has been established that the patient has osteogenesis imperfecta, and we want the, well, coarser grained concept. So it is important that we can use both the coarser grained concept and a code for that, and the finer grained, like type 1, 2, 3, 4, 5. And it's not only about recording, but it's also about selecting because, well, especially when we want to use the data for research purposes, we may want to query. We want to have all patients with any type of OI, whether it's type 1, 2, 3, 4, 5, or whether it's OI without any further specification. Or maybe even higher up the hierarchy, we may be interested in searching for all patients with a type of rare bone disease. And then it is important to see that here in the group of disorders, we see rare bone disease. I don't know if you see no, I don't think my arrow is shown. So number 5, 6 on the figure on the right. And then we see that osteogenesis imperfecta is categorized under this rare bone disease. So this helps to provide hierarchical ordering. And here we see ORFA codes, which we will hear more about in a second or a few minutes. Here we see the same for SNOMED CT, where on the second line we see osteogenesis imperfecta, and I'm not showing the hierarchy further up, but I'm showing the different types of osteogenesis imperfecta that are included in SNOMED. And here again, we see, and ordering isn't perfect, type 5, type 1, type 2, type 2A, B, C, etc. So we see that it is a common function of these coding systems to provide this hierarchical ordering, which is so important for recording and retrieving at a varying level of detail. And actually, there are many of such coding systems. So I mentioned SNOMED CT and the ORFA codes. You may have heard of the ICD-10, ICD-11, the International Classification of Diseases, and there's many more. So like in my previous example, selecting what coding system is the right one to use does require some training and tools. And then the important thing is that at a data level, we can simply describe the information about a person, in this case, John Doe having a diagnosis of osteogenesis imperfecta, and using these hierarchical systems, which are often also called ontologies, basically a special kind of coding system, then we get a lot of information for free. And for example, by knowing that John Doe is a Homo sapiens, well, we know that John Doe also is a primate and is a mammal and is a vertebrate if we go up higher up in the hierarchy. And we know all the information of osteogenesis imperfecta as it is, and all the more coarser grained concepts under which osteogenesis imperfecta is categorized. So for a user, from a user perspective, you can capture it once at the level of detail that you have at hand and that's relevant at that moment. But for retrieval, you can cluster like osteogenesis imperfecta, as I previously explained, at a coarser grained level like rare bone diseases. And all of this coding is for data, but also for metadata. That's the data about the data, contributing to making data fair. And that's basically that we ensure that the data and the metadata are easy to find for humans and for computers alike. The A stands for the fact that you know if and how you can access data, whether authentication and authorization is needed. So you need a structured and standardized description for that as well. Going through all this codification basically makes your data interoperable, which is the I of FAIR, so that it can be combined with data from other data sources. And by adequately specifying the license under which data or derived data can be reused, we ensure that a data set establishes reusability. So with that, I'd like to conclude and summarize. So we have data standardization, which is basically using schemas to specify the relevant data elements to be structured. We use data codification, basically adding a standard representation to the structure. And, well, ideally using web-based codes so that we make the data linkable and have extra information like synonyms, descriptions, and mapping information. And especially for disease identification, it leverages the hierarchical structure for storage and retrieval. And all of this contributes to making data fair. And with that, I'd like to conclude. Thanks very much for your attention. And if time permits, I'm happy to take any questions.
Thank you, Ronald. Very interesting, very informative. I think these terms are way more clearer now to everyone. I see no questions in the chat, but I wonder if someone would like to raise their hand and ask a question to Ronald now. Alan, would you like, or is that a clapping? It's a clapping. Okay, it's a clapping emoji. Okay, it was so tiny here, couldn't see. Okay, if there are no, Emily, she has a question. Yeah, go for it.
Yeah, hi, Emily. I'm from Endoweer, and but I can classify. Yeah, there's no Belgian rare bone patient, so your example was a good one. I was curious, given that the adaptation and mapping to codes here is stated as such a use, it's not as straightforward, I would assume, as that, because there are all these different types of coding, and there's not one size fits all. But is there any real project that's ongoing to map all of these types of codes together, especially I think for diseases? I'm thinking of the discrepancies maybe between ICD-10 and 11 already, and then the discrepancies further if we try to map those onto orpha codes. So do you know of any ongoing efforts really to directly map those, or do you think as well, is it needed?
Yeah, very good question. I think the last question is the easy one. Is it needed? Yes, it is. Does it happen? Well, it does happen here and there. So in some of the tools that I showed, like BioPortal, they do provide some mappings. Actually, it's always the case with things like these. You hope it gets easier, but actually there are various systems providing various mappings, and it may mean that from BioPortal you get a different mapping than you would get from the UMLS. But that's all, I think, well, that's just a state of affairs. So we are making progress, and we are fortunately increasingly harmonizing these things, but we're not there yet. One initiative I didn't mention yet is the Odyssey initiative, where they have developed not only OMOP CDM, which may ring a bell to some of you, but where they have also developed Athena, which is also a multi-vocabulary system, and where they also provide a means of basically mapping among the various coding systems. And actually also within Erdera, we are establishing what is called the Data Services Hub. And one of the things we want to do is to actually operationalize these kind of mappings to make it as well easy and as transparent as possible for people to work with well, federated and heterogeneous data sets, which may be based on, so for example, one data set being based on Orpha codes and another one being based on SNOMED codes or ICD codes, that it is still as much as possible doable to query over those somewhat heterogeneous data sets. But that's definitely work that, well, there's quite some efforts in that direction.
Sorry, we have another question. Thank you, Emily. We have another question from Anne Mael.
Yes, hello. Yes, I'm the president of a nonprofit representing vascular compression syndromes and an economist as well. I was wondering, you mentioned that we had to have some training and to select the right system because I mean they are not harmonized yet. Do you have any advice on how to select the right tools or way to get the training needed to choose them?
Yeah, so well, there's now I cannot point at a single go-to resource, unfortunately, yet. I would say maybe in the future it can be the data service hub of Erdera. But what we have done in the past is that we have been organizing summer schools with ISS, the institute in Rome. Also from the European Joint Program Rare Diseases, which was the predecessor of Erdera. And there we addressed this element to some extent. And now, for example, within Hemafair and together with Helios, we are in the domain of rare hematological disorders. Then, of course, we are also organizing a summer school where we will also address this topic. But yeah,
So it's a
I would
long
say
decision. You need a full-on training to make a decision. It's not
well,
something...
no, it's good that you interrupt me on that. It's not that we spent 3 days on doing mapping. It is basically all of the steps on verification and all of the steps of codification and harmonization that I was going through. So and even ethical and legal issues, etc. So there's much more. But yeah, I think the resources I showed are a good starting point. By the way, I have to put my slides still on Zenodo, but this will be the place. If you're looking and you can't find anything, it will be there. But yeah, I think those resources are a good starting point. And basically, my rule of thumb is always, yeah, try and find a number of prototypical examples and see what coding system works for that. And then the ontology lookup service, for example, is a good tool. And then I saw, senior researcher, it's NCIT. Patient representative is also in NCIT. Okay, then it makes sense to pick NCIT for this role, these role values. But it's a bit of playing. And I think increasingly, and with the shaping of European initiatives like a European health data space, there will be more centralized guidance as well, where, well, there will be either suggested, preferred, or even maybe like mandated or mandatory systems to be used for certain types of data elements.
Thank you.
There are 3 questions in the chat, and then we'll move to Caterina's presentation. I'm going to read the first one. How do different countries handle disease classification?
I think at large, well, most countries are member of WHO and use ICD-10 for disease classification and are, well, slowly moving towards ICD-11, and that's probably a 10-year process. I know it was for the Netherlands going to ICD-10. So that's for diseases at large, and I think for rare diseases, but I'm sure that Caterina can comment on that. For rare diseases, I think the ORFA codes are definitely one of the well, I would say well, much used or maybe everywhere used coding systems or classifications.
Thank you. Dan is asking, are different coding systems interoperable? If not, I would think the challenge of verification is not entirely solved.
Well, we're not in a perfect world yet, so there is definitely some work to do, but I do believe that the mappings that have been created do contribute to this interoperability. And like I say, there is more work that needs to be done, but I think we are well on our way in that regard.
Good. And one last question. What are the challenges in global rare disease classification?
Well, I think the first challenge there that I think of is the definition of rare disease, because I know there's quite some debate that anything that may be a rare disease in one area may in one geographic area may be a non-rare disease in another geographic area. So, and then the question is, so does this count as a rare disease? And well, I think that is a discussion that I'm happy to hand over to Caterina to well elaborate on if you want in your presentation. I see once these
One last question. Yeah. Once these diseases are coded, will their codes change again, like discarded?
So that's an excellent question. One of the rules of for people who develop coding systems is to never, ever discard a disease code. So if and it has happened for various reasons. If we have something which has a code and we find out, oh, this is wrong, or this is a duplicate. Sometimes you miss a synonym and you have two synonymous descriptions, then you will always render a code as obsolete and say, okay, don't use this code anymore for new capture of data. And ideally, you would also point out and say, oh, and by the way, this obsolete code has now been replaced by the other code that we already had or by a new code that we have introduced. So that we, well, never, and it has happened in some systems where they have reused codes. And that's, of course, the worst you can do, because then your old data basically suddenly changes meaning because patients get a different disease than they used to have because the meaning of the code changed. And that's why you can never, well, you can never discard them or reuse them, but only declare them obsolete.
Okay, good. There are no further questions, so we'll move to Caterina. Whenever you're ready.
Yes, thank you. I will share my screen.
Yep.
Okay. Can you confirm that you see my presentation in full screen?
Yeah, full screen.
Okay, perfect. Okay, so well, thank you. First of all, I'm very happy to be here to speak about Orpha codes and the Orphanet nomenclature for rare diseases. I am Caterina Lucano. I am the Orphanet scientific team manager, and my team at Orphanet basically maintains what we call the Orphanet nomenclature of rare diseases and the scientific annotations linked to the Orphanet nomenclature. So, but what is Orphanet? Orphanet is a worldwide network that offers a complete set of tools and knowledge on rare diseases and its aim is to improve diagnosis and patient care. Orphanet was created in 1997, and it's composed at the moment of 42 countries. Basically, you see the full members in blue. They're mostly in Europe, and then we have some observer countries for which we are waiting for the signature agreement, notably UK here and Greece. We have some contact points internationally, so in Canada, for example, in Australia, and we have a notable temporary suspension. In total, we have 110 people working in the different countries, and the coordination is in Paris, France. So who are the users and what are the data that are in Orphanet? So basically, our users are patients and patients' families, medical professionals, but we also have researchers, some health industry representative, and decision makers. The Orphanet website has 20 million users per year. We identify in the website a little bit more than 6,000 rare diseases. And we also link to 8,500 expert centers translated in 9 languages, and we have a total of 5 million combined data. The mission, Orphanet's mission are basically by providing reference information and knowledge to all actors of rare diseases, we aim to improve the visibility of rare diseases in the fields of healthcare and research. And we do so by maintaining the Orphanet rare disease nomenclature, so what we call Orpha codes to code rare diseases. And we, in doing so, we want to provide a common language to understand rare diseases across the rare disease fields. Our second goal is to provide high quality information on rare diseases and expertise, and to ensure equal access to knowledge for all stakeholders. High quality information means also manually curated information. So we do not use aggregators, we do not use AI. We have scientists who collect information and validate information, and then go to rare disease experts to validate it. And by 1 and 2 combine, we want to contribute to generate knowledge on rare diseases, so piecing together all the parts of the puzzle to better understanding rare disease challenges. So let's talk a little bit about rare disease invisibility in international medical terminologies. So we've seen before in Ronald's presentation that there are several terminologies for diseases, for coding diseases. So notably the WHO ICD-10 and ICD-11. ICD-10 is the one that is mostly used. ICD-11 is being implemented, is now being translated in the different languages in the different countries. There's another one that is notably being used at this moment, and is NOMED-CT. So I think that 80 countries all over the world at the moment also use NOMED-CT. And if you can see, so if you go and look a little bit into these terminologies and you look for rare diseases, basically you see that in ICD-10, 83% of rare diseases do not have any code at all. 37% of rare diseases in ICD-11 do not have any code, and the majority actually, they don't really have a code in what we call the MMS, so the main codes of the rare diseases, but they do have a URI, so a link into their foundation. So that is how the ICD-11 is structured. While if we look for SNOMED-CT, we do have an outstanding collaboration with SNOMED-CT in order for them to include more and more rare diseases, but still 7% of rare diseases do not have any code in SNOMED-CT. None of these terminologies have a code, and this is important for patients in a diagnostic dead end, so undiagnosed rare disease patient. They do have codes for undiagnosed patients, but not specifically for rare diseases. Moreover, if you look at the precision of these terminologies, so for ICD-10, you will see that 93% of rare diseases do not have a precise code, but they are included in lists, URLs, etc. And for ICD-11, 75% do not have a precise code. Again, they are maybe in the foundation, but they do not have a code in the MMS. And for SNOMED CT, we are at the same 7%. Finally, in those more general medical terminologies, rare diseases are lost among common diseases. So those generic terminologies are not exploitable for rare diseases specific statistics. So for pulling out hierarchies related to rare diseases. That is why what we offer is a specific rare diseases classification and nomenclature system for secondary use. So that is what we call Orpha codes. And Orpha codes are terminologies that are composed of several elements. So for each rare disease in Orphanet, we always have a set of elements, the first being the Orpha code that is always written in this way. So Orpha commas and then the code. We always have a preferred term for every Orpha code. That is the main name, what we call the main name of the disease. That is generally what is used in the nomenclature, in the literature as the preferred term to call a disease. But then we also have synonyms associated, as many as needed. The most important thing is that synonyms represent exactly the same concept as the preferred term. So they want, so I like to say that they represent exactly the same patient population as the preferred term, and they are just a different way of calling the same disease. We also associate a classification level because the nomenclature of rare diseases in Orphanet is not a list. It is actually structured into a classification, and the classification is structured as this. I hope you see the arrow. So we have groups that contain groups that contain groups, and then we have a single disorder level, that is the level of the confirmed diagnosis, and then disorders can have subtypes if this is, let's say, if we need to better specify the diagnosis. So these are what we call the classification levels. And also each and every Orpha code is defined by a definition that states the classification, let's say, of the disease. So for example, this disease is a rare thrombotic microangiopathy disorder characterized by, and then you have the characteristic, the clinical signs that are really characteristic of the disease. And this really helps when we need to code patients to really understand what the concept is. The nomenclature is translated, is produced in English and is translated in several languages. So you see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 languages. So what we say is that the Orphanet nomenclature is comprehensive, standardized, evidence-based, interoperable, and this is because we do align with other medical terminologies. So we have an alignment manager that basically aligns to the ICD-10, ICD-11, SNOMED CT, MESH, MEDRA, GARD, and OMIM. So it is versioned. So we do release once per year. It is computable and free. At the moment, the nomenclature includes more or less 6,400 rare diseases as defined by the European definition of rare diseases. So rare diseases in Europe. So there is a prevalence of less than 1 on 2,000. And this number was based on the July 2024 release. So we have discussed a little bit in the questions before about inactivating a code. So the Orphanet nomenclature actually is updated every month. So we have a monthly validations cycle, and decisions are always based on the current state of the medical literature and expert advices. And we have 3 possible actions that we can do in order to maintain the nomenclature. We can create new codes. For example, if a new rare disease is discovered, we look at if the phenotype is homogeneous, if the prevalence is less than 1 on 2,000 in Europe, and if it has at least 2 published cases. In this way, we can create a new code. We can modify an existing code. For example, we can modify the nomenclature term if the main name is no longer the one that was used. We can modify it according to the recent literature. We can modify the classification level. For example, something that was before considered a disease, now it's considered a group. So we can do all these kind of modifications, and we can also inactivate codes. We can inactivate codes due to several reasons. So first of all, a code can be obsolete. So it can can be, for example, a duplicate of a code, and we didn't realize, and we created it. So now we are obliged to obsolete it. We can deprecate code if in the literature there is a clear evidence that a disease that was recognized before as a specific disease is nowadays recognized as part of another disease. And we can also inactivate a code because recent studies, for example, demonstrate that the code is actually corresponding to a non-rare disease. In all of these cases, inactive ORFA codes are never reused for different entities. They can be reused for the same entities. What do I mean? A non-rare disease, so disease that was flagged non-rare at a certain point, and then another paper comes out, and the disease is actually rare, so we can reactivate the same code. However, we never reuse ORFA codes for different entities. And for each and every disease obsoleted and deprecated, we always give a reference code to be used instead of the code that was obsoleted or deprecated. And this is in order to transcode patients that were already coded with that code while doing, for example, epidemiological analysis. So what we generally say is that only ORFA codes at the moment, so ORFA codes are the only terminology that can precisely identify all of rare diseases that are fully interoperable with the most medical terminologies. So I should have made fully interoperable. At the moment, the terminology that is not yet completely aligned is ICD-11, and that is because it's an ongoing process. But our aim will be to, by the end of 2025, maybe we won't make it, but let's say by the end of 2026, having a full mapping also to ICD-11. You have, so here you have, for example, patients that are that go to a hospital, and then if you code them by using a code that is, for example, in the ICD or in the SNOMED, you might miss the rare patients, and even if you have rare patients are the one in red or in blue, and even if you have a specific code into the ICD, for example, or SNOMED for that precise disease, then you can never pull out which ones are specifically affected by rare diseases. While by using ORFA codes, basically you can be interoperable between health information systems and research settings like registries, cohorts, and biobanks. So the second part of this presentation will be a little bit more axed on how to use the ORFA codes to code rare diseases. So what are the main things that we have to keep in mind while coding patients? So here you have a brief history of what is the let's say the story of implementation of rare disease codification in Europe. I'm not going through all of it, but just remember that since 2009, codification for rare diseases was identified as a priority in the Council recommendation for rare diseases. And little by little, the Commission of Expert Group on Rare Diseases first, and then the European Commission followed by recommending the use of ORFA codes for coding rare diseases. This was coupled in 2017 with the creation of ERNs, and in 2019 with the creation of ERN registries, and at the same time, several joint actions kind of supported and produced guidelines on codification for harmonizing statistics on rare diseases. So you have 2015, 2019, the first action was the RD action that produced the first guidelines, and those guidelines were revised by RD Code 2018 and 2021. And then little by little, we now have this project that is OD4RD and OD4RD2, in which we have So we have established a network of national orphanet nomenclature hubs in 20 countries. And in these 20 countries, we provide trainings to the use of Orpha codes, workshops, and help desk for helping with codification with Orpha codes. And ongoing, there's the Jardin Joint Action that is in which Orphanet actually leads a task on semantic harmonization for rare disease data in European health information systems. So you see a real push to implement a specific codification system for rare diseases. So here you have the RD action guidelines. I just left a link for you to consult. But basically, those guidelines that were then revised in RD action and RD code, they basically identify two main domains, let's say. So first of all, they identify application domains for coding with Orpha codes, for coding, and all of those applications domain, you can see them here. So for every application domain, there is a specific recommendation on how to collect data. So for example, for in healthcare planning, what is recommended is to use Orpha code plus the main routine codification system, plus eventually a diagnosis assertion degree. For expert centers, then you have a specific data set to collect. There is, for example, Orpha codes plus additional elements such as phenotypic traits, genomic informations, etc. For research, the data set is suggested as Orpha codes as granular as needed, plus additional elements such as, again, phenotypic traits, genomic information, etc. For transnational statistics, the Orpha code statistical aggregation level was recommended for international comparability, and this is the disorder level in Orphanet. And finally, for data exchange for cross-border care, you have a minimum data set for care that is recommended, that is Orpha codes at the diagnostic level, plus, again, additional elements, depending on the planned or unplanned healthcare use case. So this is for the application domain, and then you have specified rare disease coding guidelines, and I've put them here. That's 6 guidelines that you have to know, and I'm going through each and every one of the 6 guidelines now. I'm going to pick up examples, not really big example, but just showing you a couple of things, and then as a example system, I will show you the example of the BNDMR. It's the Banque Nationale des Données Maladies Rares in France. It's a national bank of rare disease data. It's funded by the French Ministry of Health. It has nothing to do with Orphanet. It's just we really talk a lot with them, and they are the national French bank. That is the system that I know best. And basically, the BNDMR has released a system for patient codification that is called BAMARA. And I'll just talk a little bit while detailing the guidelines. So if we go to guideline 1, talks about maximizing exhaustiveness and reuse, and can also be applied to registries. So guideline 1 states that several tools and strategies could be set at the member state level to produce data or statistics for rare diseases. Nevertheless, each country should set its strategy according to the standard principle of maximizing exhaustiveness as well as possible reuse of existing data collection. So here comes, for example, one system that is BAMARA, that is not the only one that is in France. I think that there's Orbis and other data codification systems, but BAMARA is the one from the BNDMR. And it's an application used by French expert centers for collecting and retrieving data for the national minimum data set for rare diseases during patient care. And it allows for direct data entry, so data can enter directly, and interoperability. I'll show you the screen of BAMARA later on, but this provides healthcare professional with a secured and structured system to track patient diagnosis. And if we go back, basically the data from BAMARA, then they go into a data warehouse that is protected and anonymized, and those data can be used to pull up epidemiological analyses and other analyses on rare diseases. This is a very interesting system that they have. Moving on to guideline 2. Guideline 2 suggests to choose the correct granularity level to code the patient. So code the data in a way that the reporting can compile to the granularity of the international recommended list of ORFA codes. So what we recommend is to code either at the disorder level. So here you have an example of a classification. You have groups, disorders, and subtypes. If you code at disorder level or a subtype level while doing analysis, you can always go up into this arborescence and, for example, do broader analysis on leukodystrophies or rare neurological diseases. While if you code at a level that is not appropriate, for example, leukodystrophy here, the group level, then you can never go back and have the precision level you need for doing more fine analysis, for example, on Alexander disease or on Canavan disease. So really choose the correct level of granularity. Guideline 3 recommends, wherever possible, to capture the information of the diagnostic assertion for all rare disease cases. So this is what is recommended. So when for diagnostic assertion, so we need, is the diagnostic ongoing? Is it suspected? Is it confirmed? Is it not determined? So this comes from the RD code patient description. And this, next to it, is the BAMARA screen. And you can see, sorry, it's in French, but you can see that this is ongoing, this is probable, this is confirmed, and this is not determined. So for each diagnostic, the clinician can choose the information on diagnostic assertion. So, and then they can enter the mode of confirmation, and then they can enter what is the disease. So here it is based on the ORFA code. So for example, they can put the name of the disease, and the patient will be coded directly with that ORFA code. A very brief note on coding undiagnosed patients. So undiagnosed patients are those patients for which all possible up to date analysis has been conducted, but we still cannot say which diseases is the patient affected by. So in order to capture this this specific diagnosis, in the there have been some recommendation also, and one specific ORFA code has been created. That is this ORFA code 616874, rare disorder without a determined diagnosis after full investigation. And we can use it alone or in addition to the diagnostic assertion. And we can provide genotype and phenotype also for this as a side. So you have the specific code here and a specific definition that has been approved in the context of the RD code project, for which this code should only be used by expert centers and only when all analysis, all possible diagnostics have been conducted, but we could not really conclude on a clinically known concept. So moving on, I'm going to move to guideline 6 because it's easier. So the guideline 6 recommends a standardized interoperability. So when ORFA codes are used together with another national coding system for morbidity coding, for example, ICD-10 or ICD-11, the two systems should be linked in a standardized way to ensure that the codes combination are standardized. So what we do is we actually release the ORFA codes mapping with ICD-10 and ICD-11 and SNOMED mappings to ensure this univocity of reporting, to ensure this transcoding with other codes. Guideline 5, keep track for each patient files of the different ORFA codes and associated versions that were used. So for example, if a code, so if the patient was described with a code and then the code was changed, it's important to keep track of these changes, and also keep track of the patient diagnostic pathway through different codes also. So ORFA codes can be used together with other descriptors. For example, human phenotype ontology descriptions. So for example, here you have again the screen from Bamara. What is you have is here is the clinical description. So after putting an ORFA code, you can always go back and add specific clinical signs of that patient. And you can also add, and this is very important, I think, atypical signs that the patient has, but they are not maybe typical sign of that disease. And again, you can also add complementary codification such as ICD-10. So this here is, for example, ICD-10 in French, or you can add genetic information like genes and others, or other indications. So ORFA codes can be combined with other descriptor, phenotypic traits, and genotype information to complete the diagnosis, the description of the patient. And finally, guideline 4, the coding resources should be updated according to the International Agreed Cycle annually. So Orphanet nomenclature is released annually. So we recommend to update the coding resources every time a new version is released. And this is in order to have the most recent coding file and to ensure comparability between the codes. So for hospital system, we recommend the annual version of the nomenclature pack, while for the registries, there can be either the annual version or a release that is done twice per year according to the data that they prefer to use. So we offer coding support. So this is just for your knowledge so that you have the links. You have coding support through Orfadata, through the RDCode website, and through the OD4RD website. And finally, I just put here some more useful resources for you if you want to read a little bit more on ORFA codes. And here you have the Orphanet GitHub wiki session in which we really explain everything there is to know about ORFA codes and coding with ORFA codes. An online e-learning course developed by the Norway Orphanet team. Our report series, so for example, the Orphanet activity reports, and the Orphanet standardized procedure on how we produce nomenclature and associated data for rare diseases. And I thank you for your attention, and if you have questions.
Thank you, Caterina. I see 3 questions in the chat, but if anyone else wants to ask their question or raise their hand, now is the time. I'll start with Dan's question. So 6,000 plus rare diseases coded by ORFA codes. Does that mean 6,000 disorders or subtypes?
It means 6,400 disorders. So when we count rare diseases, and this is a very interesting point, there's this number that comes out sometimes in papers and so on. You have 10,000 rare diseases. This is true and not true at the same time. So if you count all rare diseases plus their, for example, etiological subtypes, so each and every gene that is associated to a single rare disease, for example, you get near to that 10,000. But then where do we put the definition of disease, of disorder actually? So what we chose at Orphanet is to keep it in the clinical, let's say, keep the clinical definition. So we group together etiological reasons for the same disease. So it's 6,400 rare disorder at the disorder level.
Sulab also asked, can an ORFA code be changed if a disease classification changes? And how does Orphanet handle updates to disease information?
So the ORFA code per se cannot be changed. So we will do several things. So when we restructure the classification, we will maintain the ORFA codes already existing. we will change the groups, for example. So if a group is no more pertinent, we will obsolete it and we will recreate a better group, and we will put Orpha codes that are already present in the new group. Otherwise, if the concepts change, at that point, we will take a decision. So if a concept of a disease has changed, we generally prefer to obsolete or deprecate and have a new code and then give the reference, so the refer to the relationship with for the new code. So we always aim to be as maintainable as possible, let's say, to maintain our code and to not change things without tracking.
Good. Thank you. Dan also asked, if there is no data available for prevalence, do you also use incidence to qualify a rare disease? And what is the threshold?
Yes. So generally, if there is no data available for prevalence, so for some diseases, we will just count the cases reported in the literature, for example. So when you have, I mean, if it's feasible, up to 200, 300, we can actually count. Incidence, we use it a little bit less because incidence, it's a bit complicated. We use it especially for infectious diseases because it's the way that infectious diseases are defined epidemiologically, and it's again 1 on 2,000, less than 1 on 2,000 for infectious diseases, while for cancers, there's a specific incidence that has been defined by the Rare Care Consortium, and it's of an incidence of less than 6 in 100,000, if I'm not mistaken. So that is specifically defined for rare cancers, and for rare cancers we only use that definition. Otherwise, we always try to calculate prevalence according to the calculation that you can do with prevalence and disease duration. So incidence and disease duration.
Okay. Now, Andre asked, I can see that some rare diseases show up in the Orphanet in some countries, but not in others. Is there any way for us individually or as organizations to support the local Orphanet admins to keep databases updated in our own countries?
You mean what you mean that they don't show up in the translated language? Because so basically the page shows up in every language, but they might not be translated yet, as we have a process of translation. So it's more or less 2 to 3 months. It takes this time for the translation country to translate and put online the version of the translation. But the page should appear even if it's not translated. So, but however, if you have a case, I'm happy to have a look after.
Is there like,
Thank you.
yeah, Andre, go ahead. Yeah.
Sorry. Thank you, Caterina. Thank you, Marta. But maybe to clarify then the question. So, for example, if I'm based in Portugal, if I go to the Orphanet, the Portuguese version, and I search, for example, for ZTTK, which is a syndrome of my son, as an example, I will not find the code information available. But for example, if I go to the German version of Orphanet, then the code is shown in there, just to give an example. So what I would like to understand is whether this is at the country's level responsibility to update, and if so, if we as organizations or even individually can do something to support those updates.
So I think that what you're missing, so I'm doing the contrary. So I'm on the ZTTK page in English. Then you can change the language and you go to the Portuguese page. And what you can see is that you're actually missing a synonym. So you don't have ZTTK as a synonym. So what you can do is you can actually ask us to add the synonym in Portuguese, and we will send a message to the Portuguese team to add it. And there is basically there is a button in Orphanet. This in English is suggest an update. And when you wait, I'll just show you in the so here you have, Sorry, a bit. So you see my screen?
Yeah.
When you
Yeah,
have
yeah.
this button here, suggest an update, basically when you are in this page, it's me who will receive this. So you can suggest the update, and we will try to notify the national team that you need this synonym added. So you see here you have the page in English, and you have the ZTTK synonym. While if you go to if you go to Portuguese, you basically only have the name of the disease and you don't have any synonym.
Okay, thanks. Actually, I was searching in the Portuguese page for that, and it showed none. Okay, but I'll
When
check
you
it.
don't find,
Caterina,
when
thank
you
you very much.
Yes, thank you.
And you have a question too.
Sorry.
And
Yes, it's me. Yeah, sorry. Yeah, just a comment to complete, Caterina. I'm taking care for Nitaka of the publication of Orphanet summary with the teams of Orphanet, of course, Esther, and all the publication. And I can tell you, it takes quite a while of time because we, as the Nitaka, we have made an online publication of syndromes, refined generally, and we have to contact our HCPs, our expert center. Then Esther will have to review with them if they have already published and not. So there is a quality for you have to be an expert to write down an Orphanet summary. And then it takes quite a while because there is a specific draft. It has to be reviewed a few times. So we do it mostly in English because that's easier. And that's why, and that's the reason sometimes there is a difference in other 7 languages, which is very usable in Orphanet. But I know that that's one of the problems we have. And even so, because it's a very huge database, if you can take all of the rare disease in this bowl, in this fantastic bowl, it takes a huge amount of time to keep up and to keep going on the things. So I know it's frustrating for the patient for that, but it's a long way of work. So that's
Thank you, Anne. From direct experience.
yeah, every day.
Every day, I know.
I see there is a final question in the chat from Fatoumata, our colleague in the Rare Barometer team. She's asking, when people with rare diseases answer our surveys and declare that they only have partial info on the disease, no name, no confirmation, we call them undiagnosed. If I understand well, as a data analyst, I cannot link them to the ORFA code for undiagnosed?
No, unfortunately not. So those patients will be in probably yet in a sort of limbo in which they have partial info but not yet the diagnosis complete. So that is not how the undiagnosed code works, unfortunately. So in order to be undiagnosed, it really needs to be an expert center that declares it, and after compiling all possible exams, like for example, whole exome sequencing and everything that is possible with today's technologies.
Thank you. I'm gonna pose one last time.
Sorry.
Yeah,
It's
go ahead.
better maybe just to Fatoumata, it's better maybe to refer them to a group of pathologies. If they have partial info, then maybe go higher and refer them to the group of their partial info if you have it. So that way at least you have a partial information.
Great. Thank you. Thank you, Fatoumata. I see no further questions, and we are 4 minutes over time. So I think we are wrapping up here. I just put a link in the chat to the attendance sheet, so you can sign in before you leave. Thank you to all of you for joining us today. Thank you to Ronald and Caterina for such clear presentations. It was clear from the questions that there is a strong interest in codification, and I'm glad we put together this session. So thank you, everyone. See you in the third webinar on I think it's on the 14th of March. Well, yeah.
We'll see. Thank you.
Yeah.
Bye-bye.
12th of March. Bye, everyone, and see you soon.
Okay. Bye-bye.
Thank you. Bye-bye.
Bye.
Thank you.